My name is Ngozi Ndeku. I'm the Missouri LCN coordinator, and today we are going to be discussing maternal health disparity in Missouri. And before we start, I would like to say Happy International Women's Day to every woman who is out here. So as we start, before we start asking questions and going and diving into the roundtable discussions, I want every panelist to introduce themselves. So in no particular order, Laura should just talk about herself and what she does for some minutes.
Hello, everybody. My name is Laura Gully. I'm Director of Community Mobilization and Advocacy with Generate Health. And our role in community is we really focus on addressing the root causes of maternal and infant health disparities. And we bring the community together around looking at what are some of those drivers, what are ways that we can collectively address and have a better outcome for children, families, and our overall community. And so I have the pleasure of working in community with community partners. We recognize we do not do this work alone. It is a collective effort, but one that we are committed to digging in and realizing a vision of what we call a bold North Star goal of achieving zero racial disparities in maternal and infant health. And so with that, I'm just going to pause because I could probably talk forever, but I can dig into it as we kind of get into the discussion today. So I am happy to be here.
All right. Hi, Karen. You're welcome. Right now we're just introducing the panelists. So Ali's going to go next, and after Ali, then you can go. So basically, you're just going to give a brief introduction about yourself, what you're doing currently in Missouri. So that's what we're just doing right now.
Yeah, sorry for the delay. I had a little technical issue getting connected.
It's fine. Ali, you can do a brief introduction about yourself.
Hi, everybody. My name is Ellie Ziegler. I'm a health policy strategist at Missouri Foundation for Health, and MFH is a statewide funding organization, and we focus on many different topic areas to improve health equity across the state. But one area that we have a particular focus is in infant and maternal health, as well as reproductive justice. So we have various initiatives along these issues where we have dedicated funding streams. And my particular role from the policy angle is to ensure that we are moving along policy opportunities in the state of Missouri that align with our initiative values and goals. So we most recently have announced our Improving Maternal Health Outcomes initiative, where we will be looking at how we can really support high quality, equitable healthcare across the state of Missouri, and do so by prioritizing data collection, community-based decision making, and greater engagement and advocacy and policy change. So that's where we're focused. That's what brings me here today, and I look forward to talking about how policies impact the health of women and birthing people in Missouri.
Thank you, Ali. Karen, you can go.
Sure. Hi, I'm Karen Harbert. So I'm the lead maternal and child health epidemiologist for the State Health Department, Missouri Department of Health and Senior Services. So my work includes being the lead epidemiologist for our state Title V block grant, which is our maternal and child health block grant. That funds a lot of our MCH programs. I'm also involved with our state maternal mortality review committee, which reviews all maternal deaths in the state. And additionally, we also have a surveillance survey that I'm the project director for, which is called PRAMS. It's a pregnancy survey that goes to moms who have recently had a baby and ask them about their experiences pre-pregnancy, during pregnancy, and then shortly after delivery. So our team here on the MCH Epi team, there's about 9 of us, mix of research epidemiologists, research analysts, and epidemiologists. Excuse me. So we generally do the data piece of the MCH world. So we work closely with our programs who who understand the importance of using data to inform their practice and make sure the programs are effective. So we do that data piece of the programs. So we have a close partnership with those who work on the programmatic side. So yeah, we work with Title V is a very broad umbrella. So it includes a lot of programs. It could be things like school-based health programs, home visiting, like Parents as Teachers is very big in Missouri. Women's health services, children with special health care needs. It's a very broad umbrella that serves a lot of the MCH community. So we do the data piece of that. And then we also do needs assessments. So when our programs need to know what are the areas of need, how should we spend this money, we provide that data. So I'm looking forward to the conversation today.
Thank you, Karen. So now we're just going to go straight into the questions for today. So Karen, I'm going to start with you because during these conversations, we're going to be using some terms, maternal morbidity, maternal mortality. So for people who are listening, what is the differences? What do these terms mean, maternal morbidity and maternal mortality? And what is the differences between these terms? And then who is currently most affected by higher rates of maternal morbidity and mortality in Missouri?
Yeah, and that's a great place to start is, did you hear these terms together of morbidity and mortality? And so I think not always people are clear on what we're talking about. So when we talk about maternal mortality, this is the cases where a woman has died either while she was pregnant or within a period of time after her delivery. So there's some few different definitions. So on mortality, if you're looking at international numbers, the World Health Organization typically uses their cutoff of 42 days. In the US, we normally go out to 1 year. The majority of our cases in Missouri happen in that gap between 43 days and 1 year. So if you look at that more narrow time frame, you miss a lot of cases. So we do use a broader time frame here for our measures. So that's what we use with our maternal mortality review committee. And then so on the other side, the morbidity. So these are kind of our near misses. So this is the case where the mom had a health complication due to her pregnancy. So this could be things like renal failure, needing a blood transfusion, having an emergency hysterectomy. You have dozens of these near misses for every case that does become a fatality. So we also study those to try to, you want to learn from these cases where you had a close call so that next time it won't be a fatality or we won't have moms who've had these really serious long-term health repercussions. So that's kind of our definition. So as far as who's likely to be affected, so we see it typically, cases are more often in urban areas rather than rural areas. There's a huge racial disparity. In Missouri, Black moms are about 4 times more likely than white moms to suffer from maternal mortality. This year, it's trended a little closer to 3 times, but that's still huge. So that's something that we're looking for. We don't see a huge difference between Hispanic and non-Hispanic, but some of that may be small numbers because Missouri doesn't have as large a Hispanic population as you might see in some other jurisdictions. But yes, racial disparity is probably the biggest one that we're focused on because it's just, that's really kind of eye-popping to hear 4 times more likely to die. So yeah, those are kind of the big groups that we pay particular attention to.
Thank you. So you mentioned there are different rates in the mortality ratio in the urban compared to the rural regions. So what factors account for these differences? Yeah,
so we don't exactly know the answer to that. So it's been a conversation that we've been having of why do we see this difference? And when we first looked at this, what I was expecting to see was that rural areas would have a higher rate. My thinking was you're far from a hospital, maybe you're not going to get to the hospital in time, and that's going to lead to a bad outcome. That's not what we saw. So that's kind of what we're doing with the PAMR board and these analysis is trying to answer questions like that. Why do we see these differences? And it could be that it really is about whether you live in urban versus rural. It could also be that there's other traits that tend to happen with these two populations. So people in urban areas tend to have a little higher income than people in rural areas. Maybe it's income that's the real difference. Maybe it's race. The rural areas tend to be very predominantly white and you have more people of color in urban areas. So it could be that race is really that confounding factor. So I would say that's a research question we're actively trying to answer and we don't have a definitive answer at this point.
Thank you. Does any of the panelists want to add to that about the differences in the mortality rates in the rural and urban region? Is there anyone that wants to throw more light on it?
Yeah, I can add a little bit of context, and based on what Karen is saying, the difference, it seems like maybe rural areas are less likely to have higher rates of maternal mortality, though I did want to point out that in Missouri, there's a measure that the March of Dimes put together looking at maternity care deserts is what they call them. So these are areas of Missouri and of other states that either have no access to obstetric care or have very limited or moderate access. And in Missouri, almost half of our counties are considered maternity care deserts. So there is no place within those counties to receive obstetric care. And that actually ends up being over 300,000 women that live in those counties with little to no care. So I'm really interested in what Karen's team is going to find when they do their analysis, and how hospital and obstetric care access maybe plays into maternal mortality or does not.
And kind of to build off what Ali said, of that, one thing that we're also starting to look at is what level of care a hospital in the area provides. So if you're kind of in a more rural area and you may have a hospital, but it's not going to have a NICU where they're equipped to deal with a really early preterm birth, or a mom who's got some serious heart complications. So that's also an area of future research, is to see how much of a difference does it make if you live near an area that has a very high level of care versus somewhere that has more limited services.
Wondering, Carrie and Ali, if you all experience or know more about kind of this trend that has happened in some of the rural places of our state that have lost hospital access to health institutions, and if that kind of helped permeate some of the issues that you're elevating around the maternity deserts.
Laura, all I know, and I prepared some of these data points before, is that since 2010 in Missouri, 9 rural hospitals have closed. And currently, or as of 2020, almost half of existing rural hospitals are vulnerable to closure. That was a talking point that was used a lot when the state was considering Medicaid expansion and whether or not to expand who was eligible for that program, because we know that rural hospitals rely a lot on the reimbursement from Medicaid patients. And so hopefully now that the state has expanded and is continuing to implement Medicaid expansion, more people will qualify and use care in rural hospitals, and therefore those hospitals, which we've seen in other states, that Medicaid expansion ends up being a real benefit to rural hospitals. So we will have to see how all of that plays out here in Missouri.
Yeah, and we've seen several rural hospitals close in the past 5 years or so. And I was really worried, are we going to see an uptick in maternal mortality, infant mortality, these really serious cases? And I was planning to do research and look into that. And then COVID happened, and it's going to be so hard to separate out what are bad outcomes that are tied to COVID versus what can you tie to this lack of access. So yeah, we do have huge chunks of the state though that if you have an emergency, you're in a bad spot because it's a long way to go to get to the hospital.
So there's a follow-up question in the chat from one of our participants, and the person is asking, like, the data, is it based on the mom's residence, and or is it not where birth occurred or where morbidity or mortality events took place?
Yeah, so we do all our data based on residence. And so the reason we do that is if you do it based on where they actually die, what it'll look like is everybody dies in big cities at the hospital. So we do it based on residency, because that's really what's telling you what are the risk factors in these communities where the people actually live. So yes, residency is how we base our data.
Thank you. So Laura, this question is for you. So what are the causes and what are the consequences of racial disparities in maternal health?
Thank you for that question. I'd like to kind of do a quick level set with what we're talking about around racial disparities, to just kind of contrast that with we're talking about outcomes that cannot be predicted by race. And that is a pretty complicated issue. So you're not just pointing to one particular issue, but it's how those systems work well for some populations in our community, while not so much in others. And so we can look at, we hate to say this, but where you live matters. Your zip code can sometimes influence and predict your outcomes. And that's something we definitely want to try to address. And so what are some of those areas? We point to, and I want to start and lead off with a topic that we don't typically, elevate or come to bear in racism. I just want to say it, that we do have a race issue in our country, and not just limited to our state and our local communities, but how does this show up and play into how we experience care and delivery, and then the access thereof. And so that impact of racism over time, we call that a weathering impact to the health of and well-being of people of color particularly. And so I'm just elevating that because it is something that when we talk about, how this shows up and the things that we really want to pay attention to, the color of your skin isn't the risk factor. It's the experience that you have associated with your race. And so I just want to provide that level of clarity. But some of the things that, I'd like to think about this being under the iceberg kind of a concept. It is those things that are driving some of the inequities and disparities, like our social determinants of health, or some people would say structural determinants of health. These are those things that impact and influence everyone every day, from socioeconomic factors like access to good paying jobs and income, and community, your ability to get to and from locations and your basic needs met. The physical environment, we also know, plays a factor and a role in, that certainly impacts the health and well-being. As we said, where you live matters. And that physical environment also plays a huge factor. Some would even say, some research even drives 40% of the barriers that were experienced or attributed to the physical environment. Healthy behaviors. So this is more kind of the individualized experience of things like tobacco use, diet and exercise, and alcohol use and sexual activity. These things also contributing to the disparities, but also access to healthcare. If you all have been tracking and following along around our kind of push for Medicaid expansion and what that, how that impacts lots and lots of Missourians' quality of care. And so we definitely, want to talk, kind of dig into that maybe later, but those things certainly drive some of the structural barriers that impact the racial disparities we see.
Thank you. So now this question is for Ali. So how has the COVID-19 pandemic affected maternal health outcomes? If it has had a effect on maternal health outcomes, how?
So I want to leave a majority of that question for Karen, since she's the one that's sort of digging into the data, and I'm not even sure if that data is available quite yet. What I can speak to is how COVID has impacted Medicaid and how Medicaid has functioned in our state during the pandemic. So currently, according to the federal government is requiring that states maintain enrollment in their Medicaid program. So if you were on Medicaid at the beginning of the COVID pandemic, then you are still on Medicaid unless you've moved out of state or for some other reason. But even if your income has changed, you have been kept on Medicaid, which has, we've heard anecdotally and from other states, has had a really large impact on the capability of people and women, especially pregnant women who otherwise would have lost coverage, to receive healthcare during the pandemic, despite all of the other sort of barriers that the pandemic has presented. That has been one, sort of light that the public health emergency has shown, and so that is one positive takeaway, I suppose. However, in the next couple of months, once the public health emergency ends, there is sort of this risk of thousands of people being removed from coverage, even if they are eligible, just because of the administrative processes that the states are going to have to go through once sort of the floodgates are open. So that's something worth tracking, and hopefully preventing, so that people who are eligible can maintain coverage. But I'll leave the rest of the question to Karen.
And sorry, I didn't catch what the original question was. I'm sorry, could you repeat it?
No, I can take it over again, it's fine. So I was asking that how has the COVID-19 pandemic impacted the health outcomes of mothers, of women in Missouri?
Yeah, so it does look like it's been affecting preterm birth, I think. So we did see a little bit of an uptick past couple of years. There has been some studies that link COVID infection to increased risk of preterm birth. And that is one of the key indicators we look at with MCH stuff, because preterm birth is so closely correlated with infant mortality. These are just critical for us to be looking at. So even if you see a bump of 1 or 2%, that's huge. That's a lot of babies. So yeah, that's really my biggest concern about how COVID's impacted MCH. And then the other thing, like Allie was talking about with insurance, I worry a lot about these moms that are going to get dropped, because what's typically happens in the state is we have moms that they might have been uninsured before pregnancy if they're low income. They get insurance while they're pregnant, and so they're able to get health care. Maybe they get diagnosed with high blood pressure, diabetes. They're able to get care for that period of time. And when they're 60 days after delivery runs out, they're kind of out of luck. And so now we've left this mom, we've given her this diagnosis, said, you're diabetic, make sure you take your insulin, here's your prescription. She has no means to fill this prescription out. Insulin's insanely expensive. And so that really worries me, of like, we've given them the diagnosis and told them what they need to do, but we haven't given them the resources to actually follow these recommendations. They want to, but if they don't have the resources, what can they really do?
And if it's okay, I'll take advantage of this moment that Karen has sort of set up about the fact that currently pregnant women on Medicaid coverage lose coverage after 60 days in normal time. So outside of the pandemic, the public health emergency. But there is a push right now at the federal level, and over half of the states have already taken action to do this, to extend coverage from 60 days to a full year. Karen mentioned before how in the United States we measure maternal mortality all the way up into that year mark. And there is a shift in thinking about the importance of the postpartum period, or the fourth trimester is what folks call it. And we know that in Missouri, a majority of the deaths happen in that later term of the postpartum period. And that is the time when women are losing coverage on Medicaid when they need it the most. So there is that option right now. And it's something that I think a lot of folks are tracking in Missouri right now.
Thank you. So Karen, this next question is for you. What metrics does the DHSS use to identify and understand maternal health disparities in Missouri?
So we do look at, from the mortality side, we're primarily using it's the pregnancy-related mortality ratio, which looks at a rate of your pregnancy-related deaths over 100,000 live births. And so that one we can do cross tabs on that, so we can break it out of different races, ethnicities, income groups, geography. So we do that on the mortality side, as well as getting into the camera data, which really goes in depth. But aside from those worst case scenarios, we use the birth files of records to see. The birth file has lots of data about who had pregnancy complications, who had different risk factors in their pregnancy, to see who's struggling, who are we missing, who didn't have access to prenatal care. That's a big one we monitor. And that again can tie back into Medicaid. So sometimes people, when they find out they're pregnant and then they apply for Medicaid and they think they can't go to the doctor until they get the card. And so they may have late entry into care. So that's one that's kind of a constant issue, to make sure that we do connect people as soon as possible, and have access to testing. If somebody wasn't planning on pregnant, and they think maybe they are, maybe they aren't, if they don't have insurance, they may take their time before they go see a doctor and see if that pregnancy can be confirmed. So yeah, I would say the birth file. We also have a lot of surveillance surveys. We use our CRAM survey, which looks at pregnancy and immediate postpartum, as well as infant health issues. So yeah, we've got lots of data, and so health disparities is always top of mind for our team.
Thank you. Ali, this next question goes to you. So, what are the consequences of poor maternal health on a household or the economy?
I think there are lots of impacts, and I would love to hear from our other panelists as well on that. I can speak to what happens when women are healthy and when they do have access to healthcare, and how that impacts our economy. So MFH recently commissioned a research study with St. Louis University that would look at the economic impact of extending postpartum coverage to 1 year. And they looked at how it would impact things like instances of diabetes, hypertension, and mental health issues, which are some of the leading issues around maternal health. And they used some assumptions that these things, if we extended coverage, these types of chronic issues would decrease in our population by 10 to 25%. And also because of that, and because of another really big cost saving issue, which is around birth spacing. So when women are given coverage, they have higher access to family planning and contraceptives. So they are more likely to wait longer between their pregnancies. And we know that when the interval between pregnancies is shorter, they're more likely to be high risk. And so when we spread them out, they're more likely to be healthy. And in this study, we were looking at how that then impacts cost, which it of course does. When you have a healthy baby, it's less expensive to the healthcare system. And so all of this together with increased access to postpartum primary and behavioral health care, the state could save over $300,000 every year. And this doesn't even consider costs that are further down the line. So when you have a healthier pregnancy and a healthier delivery, you have a healthier baby. As they grow up, they are a healthier human. And also your subsequent pregnancies will end up being healthier. So those are all costs we didn't even consider in this study that could end up adding up to hundreds of thousands, if not millions of dollars a year. And so it's just interesting to see how some of these seemingly small policy changes could impact maternal health and therefore the economy of our state.
Thank you. Laura, so this question goes to you. So what are some of the barriers of health equity in Missouri?
Sorry about that. So we know that there are a lot of barriers, certainly when it comes to improving maternal health. Let me just ask for one quick second, clarity on, can you repeat the question?
What are some barriers to health equity in Missouri?
So I would say, as I shared, kind of lifted up before, where you live, work, and play matters. Being able to improve the daily conditions of daily life would make a huge, significant impact. When I think about the data for our particular St. Louis region, elevating at 35% of our St. Louis population lives in racially segregated neighborhoods, and what that means and what that translates to our overall health and well-being of access and the quality thereof. And so we certainly know that plays a huge role in our overall health. Some of the other areas, transportation, just thinking about being able to access parts of your, like I said, getting your basic needs met. Playing, I think that certainly demonstrates a big part of our lives, mobility, being able to, access, healthcare or get availability of going to the grocery store and things of that nature. So we certainly know all of those things play a huge role in building a more equitable experience for folks in our community. So I, would certainly welcome Allie and Karen, other thoughts that you might have as well.
All I wanted to point out, and this is from Karen's data, is that in Missouri, if you are a woman on Medicaid, you are, I believe the statistic is 4 times more likely to suffer a pregnancy-related death than if you were on private health insurance. And so another barrier, although we want folks to be enrolled in Medicaid, it likely speaks to other situations that Laura is describing outside of just their healthcare coverage. Folks who are on Medicaid are more likely to be low income and live under the conditions that Laura was explaining. And so it's more than just providing healthcare. It is all of these other social determinants of health that impact your health as well.
And Missouri does still have a significant population of adults that are uninsured. So a lot of these moms that have Medicaid as the payer at delivery, they were uninsured for sometimes a very extended period of time before pregnancy. And so they're coming in with chronic health conditions that they haven't been able to get any help to manage. And so that can do a lot to affect the outcomes. And it makes it look like the Medicaid people are sicker, but a lot of it is really, they were uninsured people. The system had missed them entirely.
Thank you. So to follow up with the barrier question, now let's discuss what the solutions are to these barriers. So this question goes to both Aline and Karen, and it's what policies can be adopted at the state and local level to overcome these barriers of health equity, especially for women in Missouri. And also a follow-up question to that is, can you talk more about the role of MO Health Net in maternal health outcomes, especially in low-income communities?
Yeah, so I mean, it kind of goes back to what I was talking about before of that. It's so many of these people don't have access to care, and they don't get it and stuff when they're pregnant in those 60 days postpartum. And so you have these chronic health conditions that you just don't have the resources to deal with. And especially with the 60 days cut off, we're talking about how we see so many of the deaths, these worst case scenarios happening in that 43 days to 365. That's when we're seeing suicides, we're seeing overdoses. And these are things that if mom had good access to care, maybe she would have been able to connect with resources to get help, and things wouldn't have escalated to that level. So yeah, I mean, and it's in a lot of communities, like statewide, Health Net covers less people than private insurance, but it really depends on what part of the state you're in. If you're in a more rural, low-income area, Medicaid is more the norm. And yeah, so excuse me. So yeah, I think a lot of it just comes back to insurance is so closely tied to being able to access healthcare and medications.
I echo what Karen has said, and I think 2 really concrete policy changes along that area are, we've already decided to expand Medicaid, but implementation in Missouri has been a little rocky. So making sure that we really implement Medicaid expansion and make sure that all folks who are eligible are able to enroll. And then extended postpartum coverage is super vital and popular across the country right now. I think some other things worth mentioning are thinking about quality of care and what types of providers are being reimbursed through Medicaid. So considering integrating providers like doulas and midwives into care teams and allowing them to be reimbursed like any other provider. Another social determinant of health policy is paid family leave. So in Missouri, and like most states across the country, we don't have any type of guaranteed paid family leave. So once a mom has their baby, if they are working for their wages and they need to return to work in a week, 2 weeks, that is sometimes the case of what they are doing because they need the money. And we are actually, the United States is the only industrialized nation without any type of paid family leave requirement. We have an unpaid family leave requirement, but that doesn't necessarily help those of us who really rely on that income day to day. And then the last thing I'll mention is just continued access to contraception and family planning services through Medicaid and also Title X. You know, implementing things like 12-month supply of contraception, allowing pharmacists to prescribe contraception, just making it more accessible for all of us, and so that people are able to make their own decisions about when they want to have a child. So that is what I have to contribute. Laura, any additional thoughts?
Talking about the policy aspects of opportunities, I'm gonna call them opportunities for change. We, when we talk about really looking at addressing some of those root causes driving the disparities, we often have to surface implicit bias and opportunities for culturally congruent training and trauma-informed training that ultimately is experiencing the service delivery and the overall kind of pregnancy experience. But I just think that we can't leave this out of the discussion around what change could look like. And so I also have this spirit of optimism that if we can envision it, we can achieve it. So we have to be able to get at some of the drivers and be willing to lean into these hard discussions, some of which have plagued our communities for decades and eons. But I have to say, I'm marking the words of a colleague that talked about, let's stalk, how did she say, a bold future. Reimagining and envisioning what a changed outcome could look like. And so I'm just kind of leaning on that as we look at what those policies and practices could look like differently on the other side. So thanks, Allie, for driving me there.
I just want to say, yes, thank you for your optimism, because sometimes it feels kind of gloom and doom, like, oh, we've been facing these same problems for forever. Is it ever going to get better? It's nice to hear that, yes, we can have some hope. We are going to make a difference.
I got to stick with that, Karen, because the alternative is not going to help us get there, I tell you.
Right. So, Laura, so what community initiatives are currently in place to improve maternal health outcomes? And to follow up that question, what type of program have been most effective in reducing pregnancy complications in undeserved communities?
I think what we're talking about is improving the patient experience. I think what we're talking about is improving access. But also looking at not having to recreate the wheel, what's already working that we can invest in and pour into. And some of those things I think my fellow colleagues have kind of elevated already. We talk about increasing access to quality care, for example, the Medicaid postpartum extension. That, even though it's not a program per se, could certainly influence the ability to access care and services. Ensuring that there's increased access for doulas and midwives as additional ways to connect and build in more opportunities for them to be included in the care teams and be recognized and be able to practice in that way. So that it is kind of shifting and changing the kind of business as usual models, but really moving us into what could be, what would that potentially look like, and increasing more, not just physical aspect, but the emotional component of addressing trust and building connections with some of the more marginalized communities. Other areas or things that have shown some, let's say, some opportunities are around group and prenatal care. That those were known to build, reduce isolation, and increase social opportunities for greater outcomes. And so, those are some of the opportunities. And so I'm not going to name specific programs, but as I think about the opportunities to build more investments into the things that are already working and scaling them, that requires resources. Some intentional investments in those programs that have shown promise. And so that is another area. And then the last thing, I don't know that we've talked a whole heck of a lot about this area per se, but the maternal mental health component of this work cannot be, elevated more. When we ask community, what would make a significant impact in improving maternal and birth outcomes? And we were lifting up when moms and birthing people are healthy and well, then they're more likely to deliver healthy babies. And so that maternal mental health is a component of getting us there. And so addressing opportunities to create ways that folks could identify and build awareness that there's not necessarily stigma associated with accessing care and services, and then being able to receive the kind and type of care and services that you want and need. Not necessarily what I would say a cookie cutter approach, but really a more tailored experience for those to access the kind of care that they need.
I want to echo what Laura was saying about how much promise it seems with some of these doula and midwife programs I think these have been really great for having that extra support for mom, and not everybody wants the medicalized and hospital-based birth, and it's nice for moms where it's appropriate for their medical situation if they do have some choices. There's some different groups around the state that are focused on serving certain moms. I know at least 3 groups in the state that are focused on Black doulas for Black moms, and really having someone who you feel like is part of your community. I think that's a wonderful way to try to make a difference. And I think you mentioned it before, but I think payment's a really big barrier in those. Right now, the insurance doesn't typically cover these services. So you have to be affluent enough that you can afford to pay for this out of pocket. So we're not necessarily reaching all the moms who would benefit for this. So I think that's a real opportunity for future movement, is to make those services more widely available.
Thank you. Before we continue with the solutions, there's a question in the chat, and the person is asking, has there been much research into maternal and fetal health and nutrition in Missouri?
Not that I can think of offhand. We do a little bit of work with and just seeing how WIC can improve outcomes, but I wouldn't say we've done a whole lot that's really nutrition focused.
I personally know of some upcoming research in this area. So there is an organization in the St. Louis region, Operation Food Search. They are a food bank, but they also do lots of innovative programming. And they have a program called Fresh RX, where they are prescribing fruits and vegetable boxes to pregnant women. And they have they are working with WashU to evaluate the program, but so far have seen really amazing results in preventing maternal morbidity and mortality and healthy babies. So that is something that I think, if they get to scale, but working with some more insurance companies, that could be really powerful. So I would look out for that in the next couple of years from Missouri.
The other thing that I would lift up, it hasn't been scaled, but has a couple of different, I guess, opportunities for impact. Some of the kind of community-based organizations locally here in St. Louis have been really focused on community gardens, and the nurturing aspect of what that means hits a lot of different boxes, checks a lot of different boxes, not just the health and nutritional aspects of that kind of program area, but also the education around health and nutrition when it comes to, pouring in and identifying ways that individuals can participate in their own kind of health and wellness. And while I don't know the opportunities they've, had great outcomes in terms of published papers and outcomes, but I do know in terms of, as I think about reducing isolation, creating social opportunities, and kind of checking the mark around healthy foods and nutrition and things of that nature. So that is another kind of programmatic effort that is going on in the local area.
Thank you. So this next question is, anybody can bring in their ideas. So how can the collaboration between researchers, policymakers, healthcare professionals, and then also the community leaders, how can this collaboration between these different sectors, how does it improve maternal health outcomes?
I'd like to take a quick stab at that. As a coalition, Generate Health is a coalition, so we know that in order for us to address the issues at hand with disparities, we're going to have to work together, and everyone has a role to play. And thinking about what you can contribute. So, for example, having collaborative initiatives that tackle specific areas within maternal and child health. We have a safe sleep initiative that is really centered around, addressing better outcomes in that arena. We have a home visitation collaborative, and so that the purpose of that is bringing the collective mind together, so that both the researcher, community voices, those that are most impacted by the experiences of inequity or the service and practice and policies we're searching to address, and community-based partners, those that are on the ground delivering care and delivery. And so all of those contributing towards a collective vision of change. And I say that's stalked, what we call that stalked future. And that's what we're seeking to do. But that is an opportunity for folks to bring their talent, skills, and gifts to the collective whole.
Thank you, Laura. Now the next question is, how can rural resources be leveraged to meet maternal needs? Do we expect this to look different from what the urban program is?
Was that one directed to anyone in particular?
Anybody can answer.
Yeah, so I think in rural communities, using more virtual services could be a good option. That still requires you have internet. That's not the case everywhere. Not everybody has internet. There are places where you don't get a cell phone signal. So I'm not saying it's a viable option for everybody, but I do think it is helpful for a lot of people. I also really like a lot of the home-based services where you don't have to have transportation. Someone, a community health worker or a parent educator can actually come to your home and just meet you where you are. I think these programs can be really wonderful for getting out to families, even if you live kind of out in the sticks. Yeah, because when you're in the rural areas, transportation is so often a barrier for our low income residents of you can give them a clinic appointment, but if they don't have the means to get there, it doesn't really do them a whole lot of good. So when you're in the urban areas, the transportation barriers will still be there. Yes, you have taxi and Lyft and Uber, but can your population afford to do those? They're pricey, or the bus may take 2 hours to get to the grocery store. So you may still have, I feel like a lot of our health issues kind of come back to the lack of transportation. We can set up all the programs in the world, but if you can't get there, what good is it going to do you? So yeah, I think having some virtual and in-home options would be valuable in rural communities.
I think to add on to that, in addition to patients being able to use telehealth to be able to interact with their providers, there is a growing focus on how providers themselves can use telemedicine to talk to each other during a visit. So we talked about how in rural areas there is a lack of obstetric care, or certain, maybe there aren't NICUs or things like that. But these types of interventions can allow providers to kind of phone in an expert if the situation makes sense to do so, and allow for that care to be handled virtually while they're still in the doctor's office. So even taking that telehealth to the next level and doing more provider to provider. But again, broadband access is a huge issue in Missouri. It's something that the state has indicated a growing focus on. So hopefully we'll see some movement, especially with the huge dollars that the state is getting through the American Rescue Plan. So we could potentially see that as the new future for urban healthcare, rural healthcare.
I would say that for urban too. I think we've learned something about how we can communicate and do things differently. I know we've learned that in the education system, but certainly in the healthcare system too. So I don't think it's just applicable to rural health. I definitely see that as applicability in the in the urban setting as well.
And what Ellie's talking about with having the provider to provider, I've seen that be really valuable with mental health services for pregnant women. So there was a service that was providing a consultant, because a lot of doctors were not comfortable providing mental health medications to women who are pregnant or breastfeeding, because I don't really know, this is not my thing. And so the women weren't getting services. So now there's a group that's doing a provider to provider consultation. So if you're an OB, you're a family care doc, and you've got a woman in there, you can benefit from medication, but you can call that person who has perinatal specific training in mental health and get that that provider to provider help to make you feel confident in providing that care for the patient.
One last thing, I'm just Karen, you're sparking comments here, really around access. And Allie, you mentioned that the opportunity to expand broadband and the likes, but just technology is just not a given in some parts of our community, that A, you have it, and then B, you know how to use it. And so that is another aspect of being able to be in tune with the needs of community.
Absolutely, because when we talk about using technology for things, a lot of seniors in particular who don't have a smartphone, they're not comfortable using it, and we don't want to get them left behind when we move to more digital options.
All right, I'm here to be our 5-minute warning. We just got one new question in the chat, so I wanted to see if somebody wanted to try to tackle it in under 60 seconds before we do closing thoughts and takeaways. Might be a little bit of a challenge because I think it's a big question. So we have a question in the chat from Michelle about the risks of COVID-19 for pregnant women. And so are there any efforts that y'all know about to educate and encourage pregnant women to get vaccinated? And then again, kind of, I think going back to this question about how COVID impacted maternal mortality and morbidity, if there's anything else to add.
Yeah, so I would say from the state health department, every program we have is trying to work with these women and tell them of please talk to your doctor. It is safe for you to get pregnant or to get vaccinated while you're pregnant. It will protect your baby in those early months of life when they're too young to get vaccinated on their own. So we've got PSAs out there. We've got our home visitors talking to people in their homes, healthcare providers doing it. We are trying to get to people on all fronts and make sure that they have and answer their questions, because a lot of people who have hesitation, they're not hardcore anti-vaxxers. They're just people who have questions and they need somebody to spend some time and just answer their questions.
Fantastic. Thanks so much, Karen. All right, so in the last 2 minutes here, I'd like to give all of our panelists kind of 30 seconds to a minute to kind of highlight, is there one last takeaway, you know, if people are only going to watch 5 minutes of this roundtable discussion, what are the things you want them to leave with? What are the kind of closing thoughts you might have, something you didn't get to talk about, something you think is important? I also wanted to let our participants know, I'm going to put 2 links in the chat while this is happening. One, we have a science note written by one of our policy fellows, Dr. Jill Barnes, about maternal mortality, which is kind of a primer, relying really heavily on the work out of Karen's department and some other groups in Missouri. I'm also going to put in an evaluation for today's discussion. We always like to hear from our participants and our panelists about what things you really liked about this conversation, what we can do better moving forward. So those links are going to go in the chat. But let's start with Laura. Kind of what's your 30-second big picture takeaway for today?
Okay, I would say that if we are to significantly make improvements in maternal health outcomes, then we then can't continue to do business as usual. We will have to invest in our communities that have been disinvested in, and really engage and bring in those that are most impacted to join in designing and developing the solutions, and solutions that we know that could be scalable, that are already working in communities, so we don't have to reinvent the wheel. And then really look at and ingraining policies that can follow suit, that can help address and really target the disparities. So we, have to disaggregate our data to really understand what that means, and then build the supports from the collective whole, which again, all of the folks that are listening, you are part of the solution.
Thank you, Laura. Allie, let's go to you next.
I would just say that to remember that policy shapes our environments, which shapes our behaviors, which shapes our health outcomes. So policy is one of our strongest tools to impact maternal health outcomes. And there are lots of solutions. As Laura said, we cannot continue to do business as usual. There are lots of opportunities, and it's all connected.
Thank you. Karen.
So I think my big thing is when you're looking at making policy changes, always look at the data, because sometimes we may have a misconception going in that, for example, that I would have thought that we would have more maternal deaths in rural versus urban. We look into the data, it turns out that's not the case. So before we go making changes and affecting people's lives, we always want to look into the data and just make sure that we're on the right track, and that we have data to also measure our progress as we make changes. We want to still evaluate our progress as over time to see if is this making a difference, or do we need to kind of course correct?
Fantastic. I want to give a big thank you to our panel. I'm so appreciative of the time and expertise you brought to today's conversation. I'm thrilled to be able to learn from you and to have everybody here at the same time. So big thank you to our panel, and also to everybody who's participating today. We look forward to your feedback and continued participation in these events, and definitely reach out to us if you have any questions. Thank you again to our panelists so much. It was great to speak with everyone this afternoon.
Thank you.
Thanks so much.